Hello, I would like to welcome everyone to today's Systems for Action Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of our presentation is Addressing Social Risk Through Medical Home and Social Services Connectivity and Communication. My name is Shauna Moore, and I'm the Director of Dissemination and Research Development for the Robert Wood Johnson's Systems for Action National Program Office. We will start with the introduction, then have our presentation and commentary, and end with discussion and questions. If you have a question or comment, please feel free to type it into the chat box in the lower left-hand portion of your screen at any time throughout the presentation, and questions and comments will be addressed at the end of the presentation. I'd like to go ahead and get us started with brief introductions of our presenters, Ms. Carrie Christensen and our commentator, Dr. Amanda Brewster. Ms. Christensen is the Director of Research Innovation at the National Committee for Quality Assurance. Her industrial engineering background led her career to a career in health information technology. Carrie did her master's work in patient safety and healthcare quality and is a Lean Six Sigma Green Belt. She spent several years as a measure developer at the Physician Consortium for Performance Improvement. Prior to coming to the National Committee for Quality Assurance, Carrie worked in Chicago in the Medicaid Managed Care and Accountable Care Organization space at Medical Home Network. In 2016, she was the Phyllis Torta Healthcare Quality Fellow at the National Committee for Quality Assurance, and her research focused on social determinants of health. And our commentary speaker is Dr. Amanda Brewster. She is an assistant professor of health policy and management at the UC Berkeley School of Health. Her research focuses on emerging efforts to address social needs in the context of healthcare services. Recent projects have examined community-level patterns of collaboration among healthcare and social service organizations that care for older adults, partnerships between area agencies on aging and healthcare organizations, and factors associated with screening for social needs in physician practices. And now I'd like to go ahead and hand the program over to Ms. Christensen.
Hi, thanks. Can you guys hear us okay?
Yes.
Wonderful. All right, so thank you. We're going to talk today about our project, which is looking at addressing social risk through connecting medical homes and community-based organizations through technology, and I'll talk a little bit about that. The three organizations that are working on this project are the National Committee for Quality Assurance, Medical Home Network, and the Cook County Health and Hospital System. And we thank our partners in this work because without them we couldn't do it. And we've got two different goals for this research that we're looking at. The first goal is looking at how this increased communication between medical homes and community-based organizations facilitated by technology will impact patients, their quality of care, and their utilization of emergency and hospital services. And our second goal is looking at how this connection between medical homes and community-based organizations is affecting identification of social risk, referral to community-based organizations, communication and closing the referral loop, and receipt of services that are addressing social risk. So kind of soup to nuts, from the assessment to the actual addressing the social risk factors. So let's talk a little bit about what Medical Home Network and CCHHS are doing. They're in the Cook County, Illinois region, which is Chicago and the surrounding communities. And they've created a system called Community Care Connect. And what this is doing is taking their existing medical connection system that's connecting medical homes and hospitals, the payer, behavioral health organizations, all these different types of data and systems that are already connected, And they're layering on a connection to community-based organizations, social services systems that are out there in the environment, not currently connected to the medical care system. And the neat things about this, one of the key components is that it really does provide a 360-degree view of the patient. So all of the claims are available because this is sponsored by the health plan. They will have the ability to do bidirectional communication between the medical home and the community-based organization. And they're really understanding where their patients are in real time because they are able to understand when patients are admitted in an inpatient status or seen in an emergency department to any of the connected hospitals in the region. So that's kind of the ecosystem where this evaluation is going to happen. Let's talk a little bit about what kind of data is available. First, it's really important that we can identify all of the correct patients. So to really hone in on what our study sample is going to be, we're really interested in where they're receiving primary care and how old are they? Because we're only interested in patients that are over 18 and at certain primary care providers in the system for this study. And then layered on top of that, we are able to see information about the patient, such as demographics, gender, their medical home, what comorbidities do they have, things such as depression or asthma, drug and alcohol treatment, and then what is their self-reported level of social risk? Are they having trouble with housing insecurity? Do they have difficulty paying for medication? What's their primary language? And then outcomes, because we've got the full claims information available, we're able to look at things like utilization or breast cancer screening. Okay. What we're adding on with the intervention, adding that connectivity between the community-based organizations and the medical home, is really the elements of the communication that's happening between those two entities. So we'll be able to see things such as the reason for communication, which community-based organizations are sending the message about a patient, and what medical home is receiving or sending the message about the patient. What kinds of services are they interested in? And what's the actual text included in the message? So we'll be able to access all of that information for our research. Okay, so you can see how that's going to play into the different goals and aims. Let's talk a little bit first about the qualitative research that we're planning. For this, we are doing interviews that are grouped into sets. So for each of our interviews, we will have a patient who has been part of this intervention. So they've had bidirectional communication between the community-based organization and the medical home about them to help get their services from the community-based organization. So that patient will be interviewed, as well as the medical home staff person that served as their care coordinator or care manager, and a community-based organization staff person who worked with them to meet their needs. And the way we are going to recruit is, as shown on this slide, we're going to select 4 different medical homes that represent a diverse group of patients and different parts of the community geographically as well. And Medical Home Network will work to make sure that the staff from that medical home are willing and able to participate. And then we'll work to recruit up to 5 patients per medical home. I should clarify, medical home in this case means like your doctor's office. So the way MHN is set up, there's organizations that are either federally qualified healthcare centers or they're hospital systems-based physician practices that are affiliated with hospital systems. So a medical home could mean either one of those things in this case. So we'll find 5 patients per medical home, again, working to get a diverse group of patients who have had a wide variety of different needs, who have gone to different community-based organizations so that we get a wide range of experiences across the intervention. And then we will confirm that the community-based organization staff is able to participate as well. And we'll actually conduct the interviews. The patient interviews we plan to conduct in person, and then the staff interviews will either be conducted in person or on the phone. So that's going to help us really understand a wide variety of perspectives about how this intervention has affected their care. From the patient perspective, we're interested in a wide variety of questions. What was the process like overall for them? And then how did this connectivity potentially enable them to really be cared for more cohesively between the two organizations as they were transitioning between being cared for at the medical home and then going out and receiving services from a community-based organization and coming back to the medical home. Likewise, we'll be talking with the care managers to understand, how has this really changed the way they're doing their work? Has it changed the relationships with their patients, with the community-based organization staff? How do their patients feel and how do they feel about this new system? And what do they think has changed for them? What's the impact then? And likewise, when we speak with the community-based organization staff, we're really interested in understanding how this is going to change the way they get information about the folks that they serve and what their relationship is with the medical home. For a lot of the organizations, there has not been a standard way that they communicate and interact with people from medical homes. So this is going to be probably the largest amount of change that is experienced as a result of the intervention, how the community-based organizations are doing their work. They'll have access to information that they've never had access to before, and they'll have access to the support of the medical home in ways that they haven't had access to before. Okay, so that's going to pretty clearly play into several of the aims there, both of the goals. So let's move on and talk a little bit about where we are with the baseline data that we'll be using for the quantitative analysis. As I've mentioned, the setting of the study is in Cook County, Illinois. It's a Medicaid managed care plan, and we're working with Medical Home Network and their Accountable Care Organization, which is 12 medical home organizations, 9 of which are federally qualified health centers, and 3 of which are practices associated with 3 hospital systems. It's about 113,000 patients, and there'll also be 12 community-based organizations participating from the beginning of the intervention with the intention to add additional community-based organizations as the project moves forward. So here are some of the types of needs that is being collected at the patient level by Medical Home Network and their practices. 5 main types of needs here. We've categorized them as support needs, transportation needs, housing needs, financial needs, and demographic needs. And you can see that these are the specific questions that actually get asked of each patient. So support needs is thinking about things like, does the patient live alone? And if so, is there somebody who's a responsible adult who would be able to take care of them for a few days? For financial needs, we're interested in things like, do you need help getting food, clothing, or housing? And do you need help paying for medication? So our baseline data, we found some clear lessons in the population sample. You can see here that older patients have more needs, men have more needs, Spanish speakers have more needs, and people with chronic conditions have more needs. None of this is probably surprising to too many people on the phone. It's kind of what we expected, and it was good to see that play out in the data. Additionally, we looked at how many needs people have And we did the needs count based on those 5 categories that I described for you before, as a way of rolling it up and making sure we weren't double counting certain types of needs. So those were support needs, transportation needs, housing needs, financial needs, and demographic needs. You can see here that of almost 40% of the patients didn't have any needs that they identified themselves. About a third of the patients had 1 need, and then about the remaining, almost a third, had 2, 3, or more needs. So a wide variety of level of need in the population. We then went ahead and split those out by the same demographic categories. And you can see here that the story is really similar to the overall need in the population. Older patients have more needs, men have more needs. People with chronic conditions have more needs. You can kind of see that shift. The easiest way to see that in this data is that the no-need bar is actually getting less, right? As, for example, we moved from 18 to 29-year-old population to the 65 and older population. The green bar is getting shorter and shorter as we move down the road. Same when we look at the self-reported conditions, we can see that the green bar for people who do not have depression is a lot longer than the green bar for people who do have depression. Great. MHN also does a provider-assigned risk, and this takes into account a lot of different factors on clinical conditions, of course, and past utilization, as well as these social risks, which gives us the category here that you see in yellow, which is that folks have low clinical risk, but because of their social risk factors, MHN feels they should have additional care management to help them manage those social risks. And you can see here that the story is really similar when we're looking at the provider-assigned risk in the population. Younger patients are generally at lower risk. Men are still having more needs clinically, so they're still showing up with the increased risk there. And then people without the chronic condition are at lower risk for the provider-related risk as well. So another thing that we were able to do is compare the patient-reported risk to the neighborhood-level characteristics using the American Community Survey. And we thought this was an interesting analysis to really see, what people were reporting as their needs compared to what we would expect based on where they live and the American Community Survey profile for that area. So you can see here how the data shapes out. But let me show you kind of a breakout on one of them that we found rather interesting. We compared the financial need in the highest risk quartile, which for this area is income of up to $36,000 from the American Community Survey. So of the patients with need, which was about 14,000 patients, 53.9% of them were in the highest risk quartile. And of the patients without need, 44.9% of the patients were in the highest risk quartile. So that tells us that there's some interesting stories in how neighborhood data can help us estimate risk for patients. Because not everyone with need is in the highest risk quartile as estimated by income level. And not everybody who is in an area with high risk as estimated by their income level in the neighborhood is actually indicating that they have needs that need to be addressed. So that's just a little bit of an overview of where we are in beginning to work towards our goals and our aims for this project. And we've provided some contact information if anybody's interested in learning more. And I will move it over to Amanda to talk a little bit about some of her work and how it kind of intersects with some of the work that we're doing.
Great. This is Amanda. Thanks so much. That was wonderful to hear about the details of your project and all the great data that you're going to be collecting. So I'll start by saying that I think these results are going to be incredibly useful. As most people on the phone will be aware, there's a lot of excitement and enthusiasm in different parts of the country for trying to make these sorts of projects happen, to try to connect data sources across the healthcare sector and social services, community-based organization sector. It's really hard. So I think that the ability to document this and understand when this happens, some of the processes that led to being able to share this kind of data and use it effectively, or barriers that stand in the way, I think that will be really, really helpful for the field. So I look forward to learning from this experience. I'll talk briefly about some recent work that I've done that helps me appreciate the value of what you're going to be learning. So we can jump to the next slide. And I will tell you about some work I've been doing in the past 3 to 4 years to understand networks of interaction between healthcare organizations and community-based organizations, particularly focused on older adults, and really starting a little bit before the point where organizations might be prepared to invest together in such an in-depth information sharing infrastructure as is planned in this project. So what my colleagues and I have done to try to understand interorganizational relationships between healthcare and community-based organizations over the past few years is we identified 20 communities to examine in depth and tried to understand if we could see differences in how community-based organizations and healthcare organizations were interacting, what sorts of collaboration they were doing in communities that were achieving high performance on the sorts of utilization and spending measures that might indicate higher avoidable utilization for Medicare beneficiaries, as compared to communities that were doing more poorly on those measures. And over the course of a number of different data collection efforts, beginning with a large qualitative study where we interviewed community-based organizations and healthcare providers to try to understand what they were doing to work across sectors for individual patients or for their general population of patients, and followed up by some survey-based research where we actually asked organizations to fill out a kind of complicated network analysis survey documenting what they were doing with each potential counterpart in their organization, so how they collaborated with each of maybe 20 or 25 other organizations serving older adults in their communities in terms of sharing information about individual patients, sending referrals back and forth, planning for the future, co-sponsoring projects. And what we found was that the sorts of things that organizations did together kind of shook out into 2 different categories. And so those are depicted kind of broken out on this slide. And the first category was coordinating in the moment to care for shared patients and clients. So something like sharing information, making referrals, the sorts of work that the information sharing system in the MHN network will really be facilitating. But then I wanted to highlight that we found a separate kind of distinctive function of collaboration or kind of dimension of collaboration that's a little bit removed from the day-to-day coordination of caring for a single patient in the moment. And that had more to do with strategic planning and goal setting, so working together to assess the needs of the population that this collection of healthcare and social service agencies was jointly serving, and plan for the future. And so kind of take advantage of the collective intelligence on the population needs that might be located in, say, some in primary care clinics, some in acute care settings, and then some intelligence on population needs that's really located in the community-based organizations in the social service sector, and kind of taking advantage of that complementary awareness of population needs to do a better job of jointly planning for gaps and planning for where the gaps are and how they could be addressed. So we identified that as a distinct sort of alignment that high-performing communities in our sample tended to be really pretty advanced at. So I will end there with sharing that little snippet of observation from my work. So I think that the alignment that we see in kind of strategic planning and goal setting seem to be very important in distinguishing high-performing communities, and the sorts of interventions that link up patient share, that link up providers' awareness of their shared patients and their ability to transmit information on shared patients back and forth across different organizations, across these organizational boundaries. I think there could certainly be a vision for that, strengthening the ability of organizations to work together to understand their complementary needs and understand the population needs. As that moves forward, as that work moves forward, and on the other side, there's certainly some capacities for joint planning and goal setting and needs assessment that need to underline, kind of undergird such a ambitious project as introducing a new information exchange system. So it'll be exciting, I think, to see how this plays out over time and how these distinct types of collaboration support each other and move forward together or move forward separately. And so I'll leave it at that, and I would love to talk more about questions. Oh, and let me tell you about the second slide. Some of the work that I mentioned when we've been comparing high-performing and low-performing communities, some of that is already out in the literature. So these two slides highlight one qualitative paper that was published last year in Health Services Research, documenting the interview-based distinctions that we identified between higher and lower performing communities. And then the second paper on networks just came out this month in medical care, so documenting some of the quantitative differences we identified in organizational networks across the higher and lower performing communities. So thanks very much.
All right, thank you very much for that great presentation and the commentary. This is Shauna again, and I would like to go ahead and address some questions from those who are listening in. The first one is for folks who might be interested in doing this kind of research. Can you please share any process-related lessons learned as you've been getting this work underway? For example, have you encountered any unexpected challenges, and if so, what have you done to overcome them?
Well, this is Carrie. We just love that question so much, and I thank you for that, because we actually have been working on putting together a paper and submitting that on exactly that topic. It has been a really interesting journey. As was mentioned in my introduction, my previous role was at Medical Home Network, so they're very, very close, very close to my heart. And they are just excellent and have years and years of experience implementing technology and connectivity in the medical space. And they even learned some new lessons and had lessons that they were already aware of brought home in new ways during this process. So we've co-authored a paper with them that hopefully will come out. But let me highlight a couple of the really best practices that they've followed throughout this work that they've done to implement the system. And the first really aligns with what Amanda was talking about, building a shared vision, really understanding that everybody's got to be on board and that people have to be coming to the table as equal partners, both from the community-based organization and the medical side. And making sure that there's use cases so that both sides are getting value out of the collaboration and the sharing of information. It's not just accruing benefit back to the medical side and expecting community-based organizations to participate, but rather making sure that both sides are getting equal value from the system. Establishing methods for data sharing has been a really important message as well, especially because organizations in this space, for this project at least, a lot of them are substance use providers. So Part 2 regulations was something that has been a really interesting challenge to make sure that we've got full consent for folks to be able to share information about substance use treatment. Let's see. Shared governance kind of goes into the shared values. But things like shared terminology can be an interesting challenge as well. From the medical perspective, these are our patients. But from the community-based organization perspective, they can be clients, or they can be visitors, they can be, many other different words. So just even having something so simple as a shared terminology about how we speak about the people we're serving can make a difference when you're developing a system that both types of organizations will use. Training has been really important to make sure that we're reaching people where they need to be able to effectively train them in how to use the system. And then the final piece was really, back to that shared vision, having an advisory panel that's equally representing all the different sectors that are being served by this type of intervention. Amanda, did you have anything to add on that?
Sorry, I was muted. So I think that those are very closely aligned with my thoughts on the subject. I think that, I think actually you covered exactly what I had in mind.
All right, great. Thank you both. We do have another question. How did the healthcare providers and the community-based organizations make their referrals and communicate? Was it via phone calls, fax, or a shared technology platform?
Great. So that is exactly what we're studying here, the intervention for how that process is changing. So in the past, it could have been via any of those methods, or it could have simply been saying, if I'm the care manager speaking with my patient and simply saying, I'd like to refer you to this organization. Here's their address. Here's the hours that they're open. Let me know how it goes, right? Without really understanding or having any communication directly with the community-based organization. So moving from an environment where there's a lot of pathways for information to flow and the information may not flow, to an environment where the information is flowing bidirectionally through one standard pathway is going to have an impact, and we're really interested to see what that impact will be, both in the qualitative and quantitative sense.
All right, thank you.
And it just, I see the follow-up there, so I may as well answer it.
Okay.
The referrals will be tracked in the future state. In the past state, there was no method to be able to really track the referral except for in-care management notes, which isn't really able to be data mined in the sense that we can do a true pre and post on what percentage has the actual closed loop sense to it. But in the future, that will be, hopefully most of them will be able to know what percentage have the loop closed.
All right, thank you so much, and for following up with the follow-up question. If you have any questions, please type them into the chat box. I can go ahead and address some of my points that I picked up along the way. I thought it was a very interesting project, and I was wondering if you wanted to talk about anything that was maybe unique in Cook County, Illinois. Maybe there's a high unemployment rate or diverse demographics for this population. I think you chose this area, if I'm not mistaken, because they offer this specific plan, right? If you go back to the slide where it talks about the whole ecosystem, is that correct, why you focused on Cook County, Illinois?
Yeah, so this was an existing project that Cook County Health and Hospital Systems is funding for their own health plan, which is called County Care, that they've engaged Medical Home Network to do the technology. So it's an existing project that was funded, through the local health system, that we then have used Robert Wood Johnson's support to be able to evaluate the effects of that intervention. So it was just really good timing and a really good opportunity to look at a really large-scale intervention from a research perspective.
All right, great. And we did have a question that just came in. So this individual would like to know if you can speak to any quality improvement measures that you found within the project.
Great. So this is research in progress, so we don't have any answers. But we are interested in looking at that. Some of the measures that we suggested we might look at really look at how well the patient is engaging with their medical home, things, and how well removing the barriers of social risk factors can help them take care of preventative health that they might not be able to otherwise get to. So we were looking at things like breast cancer and colorectal cancer screening because the data is available through claims, which we have access to. We'll kind of see how that shakes out. I'm very interested in the utilization measures as well, which is not strictly a quality improvement measure, but being able to see information around reduced inpatient utilization or reduced emergency department utilization would be very interesting. And MHN has seen that in the past in connecting their medical homes to their hospitals. So hopefully this could even further enhance that reduction in utilization.
All right, great. Thank you so much. I think that wraps up our questions for today. I see that you followed up with the baseline indicator, so thank you so much. It is one of those rare times it looks like we're ending early. If you have any additional questions, we want to encourage you to reach out to the PI directly following this presentation, and we'd like to present you with an upcoming list of our webinars. Our next one will be May 22nd at 12 p.m., where we'll hear from Drs. David Meltzer and Harold Pollock from the University of Chicago on the Comprehensive Care, Community, and Culture Program. We want to encourage you to go ahead and reach out to us online at systemsforaction.org, where you can download these slides, and there's also an archive of past webinars, as well as a list of upcoming webinars. So I want to thank both of our presenters from today. It was a wonderful presentation. We hope you found informative. And go ahead and acknowledge that Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. Thank you again for joining us, and that ends the webinar for today. Goodbye.